Hi, everyone. Welcome to the IARS Virtual Education webinar. My name is Yuan. I'm a pediatric anesthesiologist from the Children's Hospital of Philadelphia, and it's my honor today to be moderating today's webinar session, where we will learn about what's new in pediatric emergence delirium, updates in detection, prevention, and treatment. Before I introduce the first speaker, I'll first go through some housekeeping slides on behalf of our sponsor, IARS. This program has not received any commercial support, and the IARS supports anesthesia research and education with an overall goal to improve patient care. This is done through support of these vital programs, many of them you may have heard of or interacted with. IARS members also have access to the following benefits. We encourage you to join if you're not already a member. IARS also provides these resources free to the global anesthesia community. And as a reminder, please join us in Seattle, Washington for the 2024 annual meeting. And there are still 10 days left to submit your late-breaking abstract to this meeting. If you missed the 2023 annual meeting, there are on-demand recordings that are available on the IARS website for members, another reason to join IARS. And after the webinar, please join the speakers in the IARS Doc Matter community to continue the conversation. And as a reminder, there are 2 upcoming webinars, and please register for them if you're interested, as you did for this one. And finally, please use the Q&A button to submit your questions to our panelists, and we'll go over all the questions at the end. So now, allow me to introduce our first speaker of the day, Dr. Quintao. Dr. Quintao is a pediatric anesthesiologist from Sao Paulo, Brazil. Although pediatric anesthesia is not recognized as a subspecialty in Brazil, he has dedicated all of his clinical and academic training to the area. He trained in his hometown, Belo Horizonte, before moving to Sao Paulo in 2017, and he is the director of the fellowship program in pediatric and neonatal anesthesia at the Faculty of Medicine, University of Sao Paulo. Please welcome Dr. Quintao.
Thank you so much for having me, and thank you, Ian and Yars for the invitation to participate in this webinar. And in this webinar, I will discuss the definitions, prevalence, and long-term behavior changes regarding emergence delirium in children. As Ian said, I'm from São Paulo, Brazil. I'm from the Universidade de São Paulo, University of São Paulo, Brazil. I have no conflict of interest to disclose, and these are the learning objectives of this presentation. So by the end of this lecture, participants will be able to differentiate between early and late postoperative and cognitive changes in children, explore the diagnostic approach for emergence delirium and late postoperative behavioral changes, outline strategies for preventing emergence delirium, and also we are going to try to investigate the potential correlation between emergence delirium and late postoperative behavioral change. Early and late postoperative behavior changes are well recognized after anesthesia for surgeries or procedures in children. And early changes occur in the immediate postoperative period, such as emergence delirium, which we will discuss in this presentation. But on the other hand, in the late postoperative period, the child may present sadness, anxiety, regression, eating and sleep disorders, tantrums, and nightmares. Emergence delirium can be defined as a behavioral and or cognitive change when the child presents a disturbance of consciousness and attention regarding the environment, disorientation, hypersensitivity to stimuli, perceptual alterations, and a hyperactive behavior. This publication, although this publication was directed to adults, we can use some concepts for children. This publication outlined recommendations for the nomenclature of cognitive change associated with anesthesia. And the emergency excitation or emergency delirium occurs after the emergency of anesthesia, so it is a adverse event restricted to the PECU. However, early postoperative negative behaviors are not restricted to emergency delirium. These negative behaviors can also be due to postoperative pain, stress, discomfort, temperament, and fear. And children who present with emergency delirium may have late postoperative negative behavior change. I recommend this editorial for the pediatric anesthesia when they discuss that emergency delirium may not just be a recovery room problem. So children who present with emergency delirium may have late postoperative behavior changes, such as separation anxiety, apathy, sleep disturbances, changes in appetite, nightmares, tantrums, nocturnal enuresis, etc. Emergency delirium can be a prevalent adverse event, which depends on the associated factors. In this survey with Brazilian anesthesiologists, 97% considered emergency delirium a relevant adverse event. When asked about the associated factors, untreated postoperative pain was listed as an associated factor, showing that pain can be confused with emergency delirium. Other associated factors listed by the respondents may be linked to emergency delirium, such as a high level of patient anxiety, high level of parental anxiety, preschool age, use of sevoflurane, ENT, or ophthalmologist surgery. And although the majority of respondents in this survey stated that they assess the occurrence of emergency delirium, only 5% stated that they use some tool to evaluate emergency delirium. Although a validated tool exists to assess emergency delirium, the PHD scale, it can be very challenging to apply on a busy clinical setting. This scale is very difficult to apply because it's very complex. So we have doubts if this scale is also applied for clinical settings or only for research. But here in Brazil, we assessed the psychometric characteristics of the Brazilian version of the PHD scale, especially when the cutoff of greater or equal to 10 is applied. And high kappa statistics, a high interclass correlation coefficient, and high Cronbach alpha were demonstrated in this psychometric evaluation. However, still, this scale is poorly applied in clinical settings here in Brazil. And despite the difficulty of currently diagnosing emergency delirium, evaluating these adverse events is very important. So this study found that kids with high pre-op anxiety and those who had emergency delirium were more likely to show later negative behaviors. And here in this work, in this study, they evaluated late postoperative behavior changes using the child behavior checklist. Understanding how children, caregivers, and anesthesiologists interact is crucial when study and dealing with emergency delirium. And this study looked into how a child's behavior during anesthesia induction relates to the likelihood of emergency delirium. And it found that children who struggle more during induction of anesthesia or showed more distress also during induction anesthesia were more likely to experience emergency delirium. And this study didn't show this correlation when the caregivers' attitudes were analyzed, both negative or positive caregivers' characteristics were not related to the occurrence of emergency delirium. Late postoperative behavior changes can affect up to 50% of children following anesthesia. And various tools are available to assess these changes, with the most commonly utilized being the post-hospitalization behavior questionnaire since the 1960s. Additionally, a newer version tailored for outpatient surgery, ambulatory surgery settings can be applied for such behavior alterations. This questionnaire, the new version of this questionnaire evaluates various behaviors and comprises 11 questions derived for the original one that had 27 questions. So each question is assigned a score, and the total score may be indicative of a new negative behavior change post-surgery or post-hospitalization. In this randomized clinical trial, it was found an incidence of an approximately 30% of late behavioral change in children following outpatient procedures when utilizing the outpatient version of the post-hospitalization behavior questionnaire. I will discuss this trial in more detail in the following slides. So regarding the preventive measures, so preventive measures for emergency delirium are well established, supported by quality evidence. And for instance, administration of propofol either prior to awakening or as part of total intravenous anesthesia or dexmedetomidine are recognized strategies to mitigate the occurrence of emergency delirium. But this matter will be discussed in more detail in the next presentation by my colleague Adam. However, can these preventive measures against emergency delirium also serve to diminish the incidence of late onset behavioral changes? This randomized trial from our colleagues in Australia investigated the use of dexmedetomidine as either preoperative or intraoperative medication compared to a control group. And the findings did not show a reduction in the occurrence of late changes as measured by the outpatient version of the post-hospitalization behavior questionnaire on day 3 post-surgery. However, as a secondary outcomes, they did demonstrate a lower occurrence of late behavioral changes on day 28 post-surgery, especially when dexmedetomidine was used as an intraoperative medication. But the primary outcome, they didn't see any difference between dexmedetomidine as a pre-med medication, intraoperative medication compared to the control group. This is the same study I presented before. And here we compare total intravenous anesthesia with inhalation anesthesia regarding the occurrence of late behavioral changes, here assessed with the outpatient version of the postoperative behavioral questionnaire. And similarly, this study did not reveal a difference between total intravenous and inhalation anesthesia in terms of the occurrence of late behavioral changes. So far, our findings suggest that pharmacological interventions aimed at preventing emergency delirium do not appear to affect the occurrence of late behavioral changes. However, it's worth noting that early changes such as emergency delirium can potentially contribute to an increased likelihood of later events. In a post-hoc analysis of the study that I presented in the previous slide, it was observed that children who experienced emergency delirium, independently of the anesthesia technique, either intravenous or inhalation, exhibited poor scores on the outpatient version of the post-hospitalization behavioral questionnaire. So it's a post-hoc analysis, but here we can show that it has a relationship between the occurrence of the emergency delirium and new negative late postoperative behavior change in children undergoing outpatient procedures. And hence, it remains crucial to mitigate the occurrence of emergency delirium in order to minimize the risk of subsequent late behavioral changes. To conclude, there is increasing attention on the occurrence of hypoactive delirium in children. While emergency delirium predominantly presents as a hyperactive behavior, it's crucial to also consider the assessment of hypoactive delirium. Like its hyperactive counterpart, there exists a scale for evaluate hypoactive delirium. It's very similar to the PHD with some domains on with more characteristics of hypoactive behavior. And despite the challenges associated with its clinical application, recognizing this scale as a diagnostic tool is important for identifying hypoactive delirium cases. And to finish this presentation, here are the key take-home messages. Emergency delirium is an important adverse event in pediatric anesthesia. Prevention is paramount, as emergency delirium tends to resolve on its own. Focusing on preventive measures is crucial. Strategies for prevention include reducing preoperative anxiety and ensuring a smooth anesthetic induction, addressing parents or caregivers' concerns and fears to create a supportive environment, and developing the ability to distinguish between pain and emergency delirium to provide appropriate management. It's also important to recognize hypoactive delirium and understand that emergency delirium can manifest in different forms. And emergency delirium extends beyond the recovery room, potentially leading to late behavioral changes in children. It's crucial to acknowledge this broader impact. So I'm here for the discussion in the end. Thank you so much. And I'll stop my presentation here. Thank you.
Thank you, Dr. Quintao, on such a comprehensive, up-to-date on pediatric emergence delirium. Our next speaker, Dr. Adam Adler, will be discussing pharmacologic and non-pharmacologic strategies for the prevention and treatment of emergence delirium. Dr. Adler is an associate professor of pediatric anesthesiology at Texas Children's Hospital and Baylor College of Medicine. Dr. Adler's research interest focuses on a host of pediatric anesthesia topics, including sleep apnea and the impacts of opioid and emergence delirium. Dr. Adler is currently working with his team to test a device for pediatric difficult airway management that they co-invented. Please welcome Dr. Adler.
Thank you so much, Ian, for that excellent introduction. So in this particular part of the lecture, we're going to focus on pharmacologic and non-pharmacologic strategies for prevention and treatment of emergence delirium. So I don't have any financial relationships to disclose, and I will not be discussing off-label or investigational uses. So in terms of agitation or delirium, so obviously an ideal anesthetic to most of us would seek to reduce the incidence of both emergence agitation and delirium, and of course to address and prevent each of these effectively. Now the real question is, does it matter? We talk about emergence agitation, emergence delirium. So these are all some of the many drivers of these two different phenomena. So a patient who's seemingly either agitated or delirious in PACU, that could be due to a lot of things. It could be due to hunger, pain, pre-existing. Sorry, I'm not sure why it's jumping ahead. Pre-existing issues, baseline temperament, disorientation, or delirium, which is one of the many possibilities. So the problem is there's a tremendous overlap with regard to patient assessment and clinical presentation. Both emergence delirium and agitation are assessed simultaneously, and there are many risk factors for perioperative stress that have been correlated with emergence agitation. With regard to the presentation, there's, like I said, a lot of overlap in the literature, both in the assessment tools that we use for both delirium and for emergence agitation, and of course the patient clinical presentation. And somewhere at the center of this is where agitation and delirium fall. So I'm sure we've heard this term a lot. Emergence agitation and emergence delirium exist on a spectrum, and that's written in many different papers. And the real question is that true? Do they? And I opine that these two have very different presentations and very different pathophysiologies. So I apologize why it's jumping ahead. I'll try that again. So in terms of looking at agitation or delirium, like we said, there's many different causes of agitation. And then with regard to delirium, I apologize, I'm having some technical difficulty. Stop the share. Seems to be advancing on its own.
Is the autoplay on, Adam?
Shouldn't be.
Transitions.
Never had that before, but I will take a look here. So in terms of emergence agitation delirium, like I said, they're two very different problems with two very different pathophysiologies. So at one end, we have agitation, which again, there's a whole slew of reasons why a patient might be agitated in the recovery period, and of course, delirium. Again, I'm not sure why that's happening. So what is... How is that?
So we see your notes as well. Let me see.
I'm not sure why it's on auto.
Oh, play So don't use time and don't play narrations. So unclick that as well.
Sorry about that. It's the first time it's ever happened to me. Okay, so in terms of emergence delirium, what really is the cause of emergence delirium? And is it just horrible agitation? So I'm not going to talk too much about EEG activity because that's going to be the focus of the next part of this lecture. But in terms of anesthetics, they do alter EEG activity. And we know that it's based on both the agent that's used and as well as the degree of the anesthetic depth. So as you can see here, we have both dexmedetomidine and propofol on the left, as well as inhalation agent, in this case, isoflurane. And we can see at different, both for different anesthetic types, as well as different depths of anesthesia, it alters EEG differently. So one of my favorite studies in this particular domain is looking at the pathogenesis of emergence delirium. And particularly, the study identified an abnormal EEG pattern during emergence delirium in children. And what they found was that there's alterations in the functional connectivity of the frontal lobe network processing during the process of emergence delirium in children. So another way to say that is this pathogenesis suggests that a child who's delirious, it's actually a frontal lobe disconnect at the core of the delirious process. And we'll look at that and we'll think about that in terms of how we're going to assess that with the PAD scale and others. So again, the problem with looking at and separating agitation and delirium is that there's so much conflicting data. For almost every medication, for almost everything that we can talk about, there's hundreds of studies on this topic, and some of them find that there is a difference, some of them find that there's no difference, and it's quite variable. And I think that there's a few reasons why I think that may be the case. There's numerous confounding variables, most particularly the risk factors for perioperative stress that are not always parsed out in terms of the study design. And of course, interchanging of the definitions. So if you look at all of the various papers, we see that the use of emergence agitation, emergence delirium are used pretty much interchangeably in a lot of papers, and that may or may not be correct to do so. So just to highlight this, this is from a single review paper relatively recently, and I'm particularly not going to put the citation for this, but this one review paper starts off by saying emergence agitation, also referred to as emergence delirium, can have significant consequence. The mechanism for which remains unclear. A paragraph or so later, they go on to state that emergence delirium is an acute confusion state. During recovery from anesthesia, patients with emergence delirium may be disoriented, hallucination, restlessness, purposeless hyperactive activity. And then they go on to say emergence delirium is not fully equivalent to emergence agitation, followed up by the terms of emergence agitation and emergence delirium are used interchangeably in this review, as in previous studies, which is true. So we almost have a definition issue as well as a mechanism for how we're going to decide on our outcomes when we're doing these particular studies. So my goal as an anesthesiologist, I think for everybody who's listening, how do I identify delirium and what things do I consider for emergence agitation? Again, I'm looking at these things almost as if they're two different problems within our anesthetic for children. And there's, of course, a significant crossover with their presentation. So as far as the PED scale, the previous lecture did touch upon this. So it's the only validated scale for emergence delirium. It's an excellent scale from Jerry Lerman. And scores above 12 increase the sensitivity for noting delirium. So just to look at this, and you don't have to memorize the score, but we're looking at this and saying the child makes eye contact with the caregiver. So again, the higher the score, the more likely you are to have delirium agitation. So not at all. Actions are purposeful. Again, not at all. Gives you more points. Aware of his or her surroundings. Not at all. And then the score again flips at the bottom over here. Child is restless or inconsolable, and you get more points for being extremely restless. So certainly if a child comes out to the PACU, they're asleep, they would have a score of 12. But the problem is as you start to wake up and the child starts to get potentially either having delirium or agitation, it's very hard. The specificity becomes a problem, right? So the way I look at this and the way I see delirium is that, like the previous paper in terms of the EEG findings, is that it's a frontal lobe disconnect. So if you have a patient and they're yelling and screaming and they're throwing themselves around, but you ask them a question and they have any kind of indication that there's a deliberate response, right? They point at something they point at an IV, they respond appropriately. They open their eyes when you call their name and look at you, even just momentarily, that to me suggests that the patient is not delirious. They're not in an altered state of or frontal lobe disconnect. It suggests that this is a person who's having some form of emergence agitation. So again, what we do for it is different, right? If someone's delirious, I think that has one pathogenesis. If someone is agitated because they have pain, treating them for delirium might be slowing down the process or not accomplishing the goals. Just for completion, there's the Watcha scale, again, trying to parse out whether somebody's agitated or delirious, and similarly, the Crevera scale as well. I think what highlights in terms of this problem and being able to compare and to think about these problems and why they're often used interchangeably is looking at this. So this is a really nice study that was published in Peds Anesthesia, and they compared all three scales at the same time in the children. I think it was 120 children in the study. And as you can see here, it suggests that an experienced observer noting whether or not the children were delirious or agitated, it seems to be possibly that that the scales maybe become an issue with specificity, and maybe they're picking up on agitation rather than frank delirium. So this is my kid. We had this experience, and I can say all the things that you mentioned before in terms of the post-operative, post-discharge behavioral issues. We faced a lot of those. So she had her TNA done in ears maybe like a month and a half ago. And she was quite anxious to begin with. She had like 3 or 4 visits to the ENT. They checked her ears, they cleaned them out, very much not happy. So a little bit apprehensive. Her initial PED score in the PACU was 12. So a few minutes later, she woke up and she was thrashing around. She probably would have had a really high PED score. She was thrashing around, screaming, yelling, inconsolable, but she was pointing to her IV. And that was the only thing that she wanted out. And she was very deliberate. Now, of course, she wasn't talking at the beginning. And then finally, after asking multiple times, what's bothering you? Are you having any pain? She kept saying out, and she's pointing at it. So her PED scale was very high, but now this is no longer suggesting that she's delirious. She actually has, the cognitive ability to point to and to explain to us what the problem is in terms of why she's upset. And I think that's an issue with emergence agitation. So let's just, for example, say giving her some propofol in terms of treatment, she would have probably, and especially knowing her, would have woken up a few minutes later and still been agitated because the problem was the IV not having a frank emergent delirium. So like I said, there's tremendous overlap with regard to assessing these things. And then the other question is, can reducing contributors of emergence agitation impact emergent delirium when we're doing these particular studies? So in terms of preoperative stress, preoperative stress increases the risk for emergence agitation. And the question is, can reducing the drivers of emergence agitation affect the PED score and ultimately result in a reduction of emergence delirium? So who is at risk for perioperative stress? Specifically children, younger children, age less than 5. And then again, between 5 and 12, it's more an issue of nerves of, environment. Of course, like I mentioned with my own kid as well, temperament of a child. So anxious children are much more likely to be anxious and have emergence agitation, parental anxiety, kids that are not in daycare or school, separation anxiety period, and of course, kids with pre-existing behavioral issues, history of previous hospitalizations and or recurrent medical encounters, and surgery without pre-medication. So pre-induction anxiety certainly increases post-operative agitation. The real question is, does preoperative stress increase either agitation, delirium, or both? So some of the interventions. So there's a lot of non-pharmacological interventions. So distraction techniques can be extremely beneficial. Those can be in the form of active or passive distraction. And the idea behind this is that the brain has limited ability to process incoming stimuli. And when you're actively engaged with doing something else, it's much more difficult to focus on a stressor or a positive input. So that can be in the form of virtual reality. There's been a whole bunch of studies on virtual reality, use of iPad. So that can be either active or passive. So allowing them to watch something, listen to music, and or actively participate in playing a game. And that's when a child life specialist can be incredibly helpful. So having a child participate actively in a game where it's very hard to focus on both the mass conduction and the environment, as well as continuing to play the game, that can be very beneficial in terms of reducing preoperative anxiety. Preoperative environments, and again, this is where child life specialists can be helpful, preparing children, especially kids who are going to come in and stay in the hospital for what to expect. As far as virtual reality, there's been a number of studies on virtual reality in terms of doing a preoperative virtual tour, showing that there's a reduction in anxiety, but no reduction in emergence delirium. There's virtual reality studied in the actual course of the induction of anesthesia, showing that there was reduced anxiety during induction, but again, no reduction in emergence delirium. This is a nice study in 638 kids looking at the difference between no parental presence, midazolam, parental presence with midazolam. And what they identified is that parental presence with midazolam had optimal induction compliance, as we might expect. And then, of course, they go on to say reduced ED intensity. So that's, again, where I think the overlap is. I think either you're having delirium or you're not having delirium. So that's the difference in the specificity between a delirious patient and an agitation patient. And I think that's where, some of the issues in terms of how do we treat and how do we identify these things become problematic. And again, going back to this, the experienced observer found that there were 7% of delirious patients when some of the other scales predicted much higher, most likely owing to the fact that they were agitated. Time to awakening is similar to the previous presenter, talked a little bit about propofol and dexmedetomidine. Shorter time to awakening can be associated with emergence agitation. How can we impact that? So another study looked at sevoflurane to a propofol transition, which showed both a reduction in emergence agitation and delirium. And there's been some conflicting evidence, the use of propofol as a TIVA and sevoflurane for a reduction in emergence agitation, the question becoming whether it actually results in a reduction in emergence delirium. And again, I think that's again the issue with a lot of these different things is, the interchangeable use of the words agitation and delirium. So as far as parental presence versus pre-meds, the excellent study that was done looking at the effect of pre-medication with midazolam, which was much more effective in terms of reducing agitation, in the preoperative period. But in terms of parental presence, can be very beneficial when it comes to certain patients. So this is a patient I had not too long ago. This is a father of a very developmentally delayed child who was very aggressive, and he came into the operating room and basically took over the function of anesthesia, and it went very beautifully. So again, I think it's there's different fits for different patients. As far as Precedex, for pre-medication, whether it's Precedex or midazolam, this is a really nice study, a meta-analysis of 11 prospective randomized controlled trials in almost 830 children. And they're specifically looking at separation, mask acceptance, agitation, and emergence delirium. So again, they use these two interchangeably. Of course, dexmedetomidine, when compared with midazolam, they found that there was a little bit better separation, a little bit better mask acceptance, and the use of dexmedetomidine was associated with a reduction in post-operative, again, agitation and emergence delirium. So in terms of the alpha-2 agonists, dexmedetomidine is probably more is significantly better when compared with clonidine at reducing both emergence agitation and emergence delirium. And it's probably a multifactorial cause, both at the EEG level in terms of the effect on delirium, as well as that idea of delayed awakening or not having a rapid awakening, and of course, probably some degree of analgesic effect and pain control. This is a study I did a few years ago. We looked at monochromatic blue light versus sham, which is plain blue light within the normal visible spectrum. I did a 104 patients randomized study, and we found that monochromatic blue light specifically has an effect on EEG, particularly in the awake stated activities. So I thought maybe, how can that impact, again, seeing that paper, the anesthesiology paper, looking at the actual driver of the pathogenesis being an EEG problem, how can potentially a monochromatic blue light, which stimulates the awake state brain waves, how can that impact emergence delirium? So I looked at this and we found that, again, using the PED scale as well as an observer, in terms of both assessments for emergence delirium, monochromatic blue light, we found an incidence of emergence delirium at just slightly less than 6% and about 33% with sham, so blue light in the visual spectrum, and the absolute relative risk reduction was 0.18. So we did find an effect, and this is again a non-pharmacologic way of addressing this problem. So going back to the original question, what are the ideal anesthetics for patients in terms of agitation and delirium? So number one, we wanted to identify patients at risk for agitation. take a multimodal approach for agitation. This can be due to a lot of things. So again, the drivers of emergence agitation, so it can be hunger, it can be pain. So we want to use regional techniques, other analgesics as needed. It could be disorientation, so getting parents in the PACU as the patient maybe has a prolonged emergence from anesthesia, let's say with transition to propofol or the use of dexmedetomidine, whether that's at any point during the case or at the end of the case, in terms of looking at reduction in emergence agitation, and then of course recognize and immediately treat emergence delirium. So in terms of that, we're going to quickly train our brain, again using the PED as a foundation, to say this patient has a frontal disconnect, this patient does not have a frontal disconnect. And I think that, to me, the way I use that is to parse out whether or not it's something that is treated best by, let's say, going back to sleep. And most of the time I will use some propofol for this, suppressing the brain activity, and almost always the patient will wake up afterwards, in absence of a state of delirium. And again, if it's because of pain and it's because of hunger or something else, I don't want to sedate that patient and again, wake up in the same cycle because it was an agitation problem and it needed a different intervention. So that's the focus that I have when I approach this subject in parsing out the difference between emergence agitation and emergence delirium. So thank you so much. I'm going to pass back to Ian. Again, I apologize for those technical difficulties we had.
Thank you, Adam. Thank you for the overview on the prevention and treatment options for both emergence agitation and emergence delirium. And our next speaker, Dr. Jerry Chao, will be discussing EEG correlates of emergence delirium and anesthesia. Dr. Chao is an associate professor of anesthesiology at the Albert Einstein College of Medicine, Montefiore Medical Center, where he practices pediatric anesthesiology. His interests including obtaining EEG correlates during general anesthesia and spinal anesthesia to inform our understanding of early anesthesia in the brain and neurodevelopment. Please welcome Dr. Chao.
Thank you so much, Dr. Yuan. Is everybody able to see my slides?
Yes, we can.
Thank you. As far as disclosures, I have no financial relationships with commercial interests. I'm supported by a K-23 Mentor Research Career Development Award, and my presentation does not include discussion of off-label or investigational use. So my learning objectives today are to discuss what information the electroencephalogram or EEG conveys, and then I wanted to take a deep dive into two papers as an efficient high-yield use of our time today. The first of which is the Kim et al. Paper from British Journal in 2021, because it's a particularly salient and effective piece of literature that describes the methodology and concepts of EEG research, as well as a discussion of what has already been discussed, which is some of the challenges of classifying emergence delirium or agitation. And then as Dr. Adler described, I also wanted to discuss the Martin paper from Anesthesiology in 2014 for its impactful findings and what it can mean for our understanding of the neurophysiology of emergence delirium. I'll then present the references, and then we'll open up for questions and discussions. So the electroencephalogram, or EEG, is just one example of a measurement of brain activity that can be obtained during anesthesia. And so this schematic from a basic neuroscience text shows a single surface scalp electrode, which is capable of measuring underlying voltage changes that are generated from neurons. Neural transmission and action potential propagation leads to changes in the charge and voltage environments in the extracellular environment, generating a transient negative charge. And this is measurable at the surface scalp electrode as a negative deflection. And so briefly to summarize, the EEG reflects the activity of the brain, of the underlying neurophysiology, and it can provide important information such as the brain oscillatory activity, as well as the quantity of power or oscillatory energy within a given range of frequencies, for example, the slow delta frequency bandwidth. And crucially, the power-frequency relationships how much quantity of the amplitude within frequency bandwidths, how this relationship can change over time. And the lower right-hand figure there shows an example spectrogram, which shows frequency power relationships as a function of time. So Kim and colleagues studied the frontal EEG activity during emergence from general anesthesia. And they compared this to children who developed emergence delirium, ED, compared to those who didn't. And it's a fine illustration of the powerful glimpse that EEG can provide, as well as an illustration of important limitations and challenges, some of which were already described. And so as far as the methods, this was a single center observational study among children aged 2 to 10 years old undergoing sevoflurane anesthesia. Emergence delirium was assessed according to the DSM 4 or 5 criteria, as well as some of the other scales, which I'll go into more detail later. They looked at the relative power of low frequency, delta and theta, as well as high frequencies, alpha and beta. And they compared these between children who developed emergence delirium versus those who didn't. They also looked at linear relationships between relative power and peak pediatric assessment of emergence delirium, PAED scores. And so 60 subjects were in this study. 22 of the subjects developed emergence delirium, whereas 38 did not. And so the investigators observed that the relative power of the delta frequency bandwidth was higher among the children who developed emergence delirium. Relative delta power was higher, whereas alpha and beta relative power was lower in these children who developed emergence delirium. They looked at the area under the receiver operating curve to look at the discriminative power of relative power between children who developed emergence delirium compared to those who didn't. And then they also investigated linear relationships between the relative power and peak PAED scores. They concluded that children who have increased low-frequency delta frontal EEG activity had an increased risk, or this was a hallmark of the development of emergence delirium from general anesthesia. And so to go into some more granular details about the anesthetic management, it was at the discretion of the attending anesthesiologist, primarily for eye or ear, nose, and throat surgery requiring general anesthesia. In this study, all children were pre-medicated with midazolam IV or ketamine IV, reflecting the local practices of the authors. Sevoflurane induction occurred, which was followed by sevoflurane maintenance. And in this study, the investigators targeted a BIS range of 40 to 60. As far as the emergence delirium outcome measures, upon PACU arrival, researchers assessed emergence delirium and pain scores every 10 minutes using the PAED scale, which ranges from 0 to 20, or the WACA scale from 0 to 4. Pain was measured using the FLAC score, face, legs, activity, cry, and consolability, which ranges from 0 to 10. If children had PAED scores greater than 12, with a WACA score greater than 2, or if FLAC scores were greater than 4, half a mic per kilo of fentanyl was administered. Crucially, the classification of emergence delirium was a qualitative one. So using the information from these scales, at the end of each case, the two researchers compared their case report forms, and they agreed on the determination of emergence delirium based on the DSM 4 or 5 criteria. The BIS was used, which records 2 frontal channels on the left side of the head, F3 and F7, during the period of emergence in the study, which was defined by the authors as cessation of sevoflurane at that moment in time to upon discharge from the operating room. They looked at 4 frequency bandwidths: the canonical delta, or 1 to 4 hertz frequency bandwidth, theta, alpha of 8 to 12 hertz, and the beta range. They applied computational approaches to the EEG data to calculate the absolute power of each band. And then their final outcome of main interest was the relative power, which is the ratio of the absolute power of each band to the total summed power across the entire 1 to 30 hertz range. And you see the formula right there for the delta. And so figure 1 shows a flow diagram of patient enrollment. 87 subjects were assessed for eligibility, with a final 60 subjects included into the study. And you can see here that the classification of emergence delirium consisted of 22 children compared to 38 children who were not classified as having emergence delirium. Table 1 shows patient characteristics, and of note, I'll direct your attention to the emergence time. So the emergence time among children who did not get classified with having emergence delirium was significantly higher compared to children who did develop emergence delirium. 12 minutes for emergence time compared to 9. As expected, the children who were classified as having emergence delirium had higher peak PAED scores, peak WACA scores, as well as peak FLAC scores. Table 2 shows relative and absolute power of brain waves during the emergence period. And I'll just direct your attention to the delta relative power, which was the main outcome finding of the investigators. And so the relative delta power was higher, significantly higher among children who developed emergence delirium compared to those who did not. The receiver operating characteristic curve, or ROC curve, for the delta fraction in this figure, or the delta relative power, had an area under the curve, AUC, of 0.837. And you can see that indicated by the red arrows, indicating the light blue dots and lines on the curve. And so delta relative power is good at discriminating children who developed emergence delirium compared to those who did not. Figure 3 shows the linear relationships of peak PAED scores with relative power at different bandwidths. So the top left panel, you see there that as relative delta power increases, the peak emergence delirium scale score increases. So there's a positive association. The more slow frequency relative delta power during emergence, the higher the peak PAED scores tended to be in those children. The inverse is true for relative alpha power. And so you can see a negative or downsloping line such that in children with higher levels of alpha power, their peak PAED scores tend to be lower. So the research shows that certain EEG patterns that are measurable during the period of emergence from anesthesia are strongly associated with emergence delirium in children, including, again, high relative delta power, as well as an increased ratio of the low frequencies to high frequency oscillations. Transitioning rapidly the thought from deep anesthesia to wakefulness might predispose children to emergence delirium. And this is reflected by the absence of an EEG pattern resembling non-rapid eye movement stage 2 sleep. So the limitations of the Kim et al. Study include the challenge, as already been described, with classifying or diagnosing emergence delirium. In this study, the incidence was relatively high, 22 out of 60 subjects, or about 37%, which is higher than some other studies. And the authors state that the diagnosis or the classification was a qualitative one using the DSM-4 or 5 criteria. The authors noted that high delta relative power does not always indicate emergence delirium, quite simply because of the fact, by virtue of the fact that some children who had high delta relative power didn't end up developing emergence delirium or agitation. They go on further to talk about the lower levels of the hyposomatic, I believe, form of delirium that was discussed earlier. There are trade-offs. Two-channel EEG, there's a practicality component balanced against potential limitations in the breadth of data that can be collected. And then finally, there wasn't an opportunity to record baseline EEG. I'll move on to the second study by Martin et al., which was mentioned in the earlier talk, looking at alterations in functional connectivity of frontal lobe networks preceding emergence delirium in children. And so the key points here in this study, the authors investigated children, and among those without emergence delirium, an EEG pattern of sleep or drowsy state was observed before peaceful awakening. In contrast, children who developed emergence delirium had an arousal with clinical delirium that occurred before the observation of any EEG patterns resembling sleep. Importantly, in their functional regional connectivity analyses, there was an observation of a significantly elevated activity in frontal regions among children who developed emergence delirium compared to those in matched controls. This is a flow diagram looking at the 12 subjects that were studied, describing state transitions of the children who did not develop emergence delirium compared to those who did, from the point of terminating sevoflurane administration to awakening. The state transitions that are indicated by the boxes are categorized according to behavioral and EEG patterns. And so I'll direct your attention to the indeterminate state box, which was described by the study investigators as a pattern of diffuse mixed alpha and beta frequency activity. And you can see here that going towards the right-hand side of the flow chart, that children who did not develop emergence delirium exhibited a state of EEG patterns and behavioral patterns that resembled sleep, the sleep or drowsy state. Those children then continued and progressed to awakening. In contrast, it's thought that the children who developed the delirious behavior with motor activity, sometimes without emotional distress, that in these children, their brainwave patterns seem to bypass this state of sleep or drowsiness, suggesting that that's an important part of the pathophysiological process of the development of emergence delirium. In terms of limitations, the sample size consisted of 5 subjects who developed emergence delirium compared to 7 selected subjects who did not. And then the overall incidence of emergence delirium was relatively low, however, still in line with previous research. 5 out of 60 subjects in the overall cohort were about 8%. And so my concluding thoughts, using the EEG to study emergence delirium is rational, as it's an objective measure of brain activity. And there's a rich contextual literature that has already begun to examine alpha power, delta power, and other EEG patterns in adults and in children, and what their clinical significance might be during anesthesia and sleep. However, as described by other speakers, there are important challenges, including the variable incidence, ranging from 8 to 37%, the technical challenges of obtaining EEG data during pediatric anesthesia, and the complexity of computational approaches to the EEG data and its interpretation. Nonetheless, future innovative research can address limitations and has the potential to expand our knowledge. And so here are the references. There's the Kim et al. And Martin et al. Papers. The Koch papers looked at epileptiform discharges, as well as intraoperative burst suppression and their associations. And then some additional papers here with a review paper at the bottom. Thank you.
Thank you, Jerry, and thank you all three for excellent talks. I'm going to review the Q&A panel and see what we have here. We have a few minutes. We're just at 5, so maybe 2 or 3 minutes of Q&A. And if you haven't typed your questions in, now's the time to do so. I'm going to start off with Danloff Tracy's question. He says, I find that I have less emergence delirium when using isoflurane as opposed to sevoflurane. I assume it's because the child wakes up a little slower. I saw this change profoundly in the 1990s when we started using sevoflurane. Why are so many people not using the isoflurane anymore? This is, I assume, addressed to all three of you. Anyone can take it.
Yeah, I think it's definitely hard to say why people, why practices, and I think it's very institutional dependent. I can tell you here at Texas Children's, I mean, up in cardiac for different reasons, we mostly use isoflurane, and we do deep extubations in the general OR. I think people find that, it's potentially faster to do things with sevoflurane. Again, I think it's just variation in practice, and the need for adjusting your timing based on which agent you're using. I think a lot of providers, certainly in the last maybe 10 years, seem to have gone to, maybe less sevoflurane and the addition of things like dexmedetomidine as it's become more widely available and less expensive to use. But that's an interesting observation.
Any other responses before I move on to the next question? 3, 2.
Okay, go to the next question.
Okay. This question is from Dr. Morgan. Dr. Chao, I am curious why Chiminol focus on increased delta power rather than decreased beta power. We generally consider high frequencies as indicative of wakefulness. Were they looking at patients that remained anesthetized?
Thanks so much, Dr. Morgan, for the question. The study investigators looked at delta relative power as their primary main outcome measure, and they also looked at alpha and beta relative power as well. And they observed that, as you saw in that linear regression figure, that there was also a negative association. So the alpha power, higher levels of alpha power during emergence seemed to be associated with lower peak PAED scores. They also did a ROC analysis, a ROC curve and an AUC analysis, and the discriminative power was even lower. The AUC was 0.7, in the 0.7 to 0.8 range.
All right, thank you. Next question is from Dr. Caitlin Eslinger. As experts in the field, what gaps in literature do you feel need to be closed? This is for everyone.
Well, I believe that the method that Jerry discussed, the EEG patterns for the diagnostic of emergency delirium, especially when children present epileptic patterns in the EEG. So this may be related to emergency delirium or not. And maybe, I don't know if it's possible to answer this question in the future. It's regarding the epigenetic modifications, and especially in those children that are frequent flyers in the operating room. So I don't know, it's not known if the previous emergency delirium is associated factor for a further emergency delirium, but maybe some studies regarding the epigenetic modifications for those children as a frequent flyer, maybe it can answer some questions regarding the occurrence of emergency delirium.
Yeah, I agree with that. I think, certainly the post-discharge information, I think, is important as well. I think there's people who are starting to touch upon that and who have in the past. But what is the long-term impact, if any, does actually having delirium have on a patient post-discharge? Would be something of interest to study further. I go to the next one.
Yep, Dr. Chao, anything to add, or I'll move on to the next one?
Nothing to add here.
All right, this next question is from Joshua Leifer. For the second speaker, Adam, can you walk us through your management stages of an anesthetic of an awake extubation in a patient with a high risk for emergence delirium?
Yeah, so great question. So I, in this particular environment, there's a lot of people who do deep extubations. I tend to go on the side of awake extubations. And when I say awake, I don't mean like awake, cognitively, but fully spontaneously ventilating. They might be a little bit asleep, with regard to sedation from, let's say, dexmedetomidine. I try to consider all the different aspects. So if it's something that can be done with a regional anesthetic, plus the addition of something like dexmedetomidine, we'll do that. And then if there is an opioid required, to make sure that I control pain. So I'm controlling the different aspects that I can with regard to some of the drivers of the agitation. And then, with that, oftentimes I will see a more quick awakening than, of course, you would see with the deep extubation. And then when I start to see, and I would say I get a fair amount of, early onset of what I would, consider to be delirium. So a patient who's doing the typical signs of, disconnect with their environment. And that's something that I will quickly treat with propofol. So I'll treat them that way. For me, I get to treat them. The small amount of propofol maintains maintenance of spontaneous ventilation. At that point, I'll go to the PACU, and by the time I'm done, discussing and providing the sign out to the PACU nursing staff, I'm typically past that period. So number one, to again preempt what the drivers are for agitation. So we talked about some of the things in terms of perioperative stress. So looking at some of those things, patients that would benefit from, let's say, a pre-medication and/or parental presence, if they have developmental delays, special needs, et cetera. And then, of course, using those adjuncts, regional opioids, dexmedetomidine, to augment, both for delirium and, having some, especially giving some dexmedetomidine at the end of the procedure to have that ability to have that additional sedation kind of carried through PACU, and to make sure we have the pain control as well.
Thank you, Dr. Adler. That answers on the next question too by Dr. Gabriel Serraris. In a practical way, what would you suggest to reduce emergence delirium? I think Dr. Adler just went through that. So the next question is from Dr. Landino. Is there a difference between the EEG patterns in hypoactive and hyperactive delirium? And this, I presume, is for you, Dr. Chao.
Yeah, I'm not sure. I haven't been able to come across that in my review of the literature. I think the question speaks to what's been described by the two previous speakers, the challenges, and in this line of research, the challenges of classifying emergence delirium. I use the word classification, but sort of identifying or diagnosing emergence delirium, emergence agitation, in the point of care clinical environment, much less for research purposes as well. But no, I haven't. And that's one of the limitations stated by the Kim et al. Group, referencing an article published in Pediatric Anesthesia by, I forget the name of the first author. It starts with an M, but the senior author is Dr. Andrew Davidson, again, describing the use of the DSM-4 or 5 criteria to qualitatively diagnose emergence agitation, emergence delirium, if I understood correctly, utilizing the various other scales that were described, the PAED scale, the WACA scale, et cetera.
Thank you, Jerry. The next question is from Dr. David Rosen. In the old days, when we had emergence delirium, we administered physostigmine. Emergence delirium stopped in seconds, and agitation was not affected. Why do you think this happened?
That's a good question, and I'm not sure I have a good answer for that.
Have
Me
any of
neither.
you used
neither.
physostigmine before for emergency delirium?
No.
For emergency
Actually, I believe that we don't have access to physostigmine here in Brazil, only neostigmine, and I don't know. It's we can use neostigmine for emergency delirium, considering the adverse events, but I never heard about that.
Okay.
I'm sorry.
All right, we'll skip to the next question. Sorry, Dr. Rosen. This is from Katrina Duke-Cape. How do you balance the need for rapid awakening to optimize operating room throughput, efficiency, particularly in ENT cases, and the use of dexmedetomidine to help decrease incidence of emergency delirium, which slows awakening? How and when do you dose dexmedetomidine?
So that's a really great question. And it's an argument I've had with many people. So for example, so I'm going to use it, the ENT, as you mentioned, as the example. So my anesthetic for, let's say, a tonsil and adenoidectomy is I will typically keep the patient spontaneously ventilating. So in our practice here, at least in the US, or most of the time, we do an inhalation induction followed by IV placement. By the time, and mostly for the younger children, by the time that's done, you're pretty much able to intubate the patient, I would say, without any additional medications. Sometimes if they're a little bit older, to blunt the airway reflexes, we'll give some propofol. And at that point, I will typically give my other adjuncts, whether that's morphine or fentanyl or some type of opioid, the remainder of the medications, and I'll use dexmedetomidine. So in a study I did a few years ago that we published, we looked at the opioid reduction effect, or how much you would need to get some pain or analgesic effect, and it looked like 0.5 per kilo and above was the amount to give for that. So typically I'll give 0.5 per kilo or above to be able to reduce the amount of opioid. Again, it's not my initial intent, but in terms of for those looking for an opioid reduction effect, so I'll give that in conjunction with an opioid, and again, maintenance of spontaneous ventilation. And as I'm giving this other medication, I'm turning back the amount of the volatile anesthetic, and I aim to extubate the patient at the end, again, spontaneously breathing. And if they do have some agitation or delirium, I'll able to treat it there with propofol. Again, I have a good assessment of the degree of analgesia in terms of both their heart rate, but in terms of the respiratory rate, because I'm not controlling that at all. And that's how I'll typically formulate an anesthetic to be able to extubate at the end of the procedure without having an undue prolongation of PACU. I think if you give the Precedex or dexmedetomidine at the end of the procedure, in very high doses, you might see a little bit of a delay in emergence and discharge from PACU. But if you give it right up at front, again, I think some of it has to do with who's doing the surgery. If you're at a institution that has a lot of trainees and these things take a little bit longer versus you're at say a surgical center where it's staff physicians only and they're doing it more quickly, I think that's all relevant. But typically, you don't see that there is too much of a delayed emergence from PACU when I do it like that.
Thank you, Adam. I think the sponsors have told me that we have probably time for 2 more questions. The rest of the questions, if they are not answered, will be exported to the chat forum, and they will be emailed directly to the panelists so that they can respond to you directly. And the next question is from Pablo Sepulveda. Thank you for your talks. Do you think that in an oscillation and dynamic system like the brain, if you produce an intense perturbation, IV or inhalation induction, we will have a very depressed condition to obtain an alpha band similar to non-REM sleep? All these systems have inertia, and probably all data obtained with fast induction are difficult to compare. I think this is another EEG question.
Yeah, I think if I understood the question correctly, if there's differences in EEG responses in brainwave patterns in response to a bolus IV or inhalational induction. I think it's been shown that when you administer a large IV bolus of, say, propofol, you develop a low voltage pattern. And in that acute period where the central nervous system is sort of flooded by drug effect, we're not able to observe an alpha frequency band oscillation. And it takes some time for recovery from a low voltage pattern to an alpha frequency pattern, for example. Inhalational induction, I think with high dose sevoflurane, we might also observe that effect, some low voltage patterns, but it's not as common as an IV bolus. And then as far as non-REM sleep, the low voltage patterns from more intense perturbations, it does not seem to resemble non-REM sleep, which has a certain frequency property to it.
Thank you. All right, down to the last question. And I have to say, I went through the Q&A, some of the responses and questions. There are a lot of questions, very good questions, a lot of very good responses. We hope to continue this offline. But the last question I have is, sorry, let me find it. All right, this is from Dr. David Hoppenstein. Do you see a relationship with surgery type and emergence delirium / agitation?
Yeah, so I think there's conflicting data and discussion in the literature, possibly owing to the difference between delirium and agitation. Certainly, in the absence of noxious stimuli or something like an MRI. I mean, again, you can get emergence delirium and agitation. So there have been reported differences. Certainly the ENT and ophthalmologic procedures, I think, are a little bit higher of an incidence than some others. But I think it's a good question.
All right. Thank you to our panelists. Thank you to our sponsors. And I'm sorry, Danielle and Katrina, we couldn't get to your questions, but they will be saved and forwarded to the speakers. Thank you, everyone in the audience.